Welcome, everyone. Thanks for being here. My name is Jeff Luce. I'm the VP of East Coast Operations at Optum. Happy to be moderating this panel of great folks. We're going to be talking about SMI engagement. We got a lot to cover. We're going to just go ahead and jump in. Let's start with intros and just intro and where are you from, organizations, all that.
Good afternoon, everyone. I'm Crystal O'Brien. I am with Optum Behavioral Health. I sit on the provider enablement team, and I'm the director of solution and design, and have been focusing on the development of value-based programming specific for the SMI population.
And I'm Joe Parks. I'm a psychiatrist. I'm chief medical officer for First Hand, and we're a company that uses peer-based services to do outreach engagement, urgent care, and population health management to get unengaged people back in the good services that are available that otherwise they do not get.
Hi, I'm Manish Sapra. I'm a psychiatrist. I'm executive director for the behavioral health service line at Northwell Health. Northwell is a health system in New York, over 21 hospitals, 2 freestanding psych hospitals, and my background is community and population health, and it's really interested in talking about issues germane to severe mental illness.
That's great. I think let's just go ahead and jump right into the big question, which is engagement, right? This is a topic across all populations, across many panels today. I think particularly challenging here with this population we're talking about. So just how would you kind of frame up the differentiators? What's different in this population from an engagement lens? Crystal, you go ahead.
Jumping into the hard ones at first, yeah. And so I'll be frank. What we're seeing is that the delivery of field-based staff is going to be key to engaging this population. Any type of digital first, telephonic first, cold calling, if you will, simply isn't going to be sufficient enough to engage this population. Imagine for a second you're an individual with an SMI diagnosis and you do get a cold call. You decide to answer it. You're feeling good that day. You're told, hey, let's do an assessment. But before then, I'm going to tell you, 1, that you're on a recorded line. 2, you have to tell me your date of birth and your zip code for me to talk to you. So that's how payers right now are trying to engage this population, and it's a barrier to care. It's not going to work. What we're seeing is that multiple modalities really are key. So not only are we going to make sure that there are opportunities for telephonic work, even snail mail if that's an option, but having a feet on the street approach is going to work the best. We're seeing a much higher engagement rate for those providers who are sending their staff out in the community, literally knocking on doors, being there when the individual needs them the most, whether it's in a homeless shelter or in an inpatient unit, having the ability to have someone right there when you need them to start building that trusting relationship.
I couldn't agree more. What they are unengaged, not just that they're unengaged, but many of them have decided to actively avoid us. And it's because they don't like the way we're treating them. And if we're going to get them engaged, we have to treat them differently, which means we have to start with asking, what do you want? And then we have to stick with that for a good deal of time instead of immediately switching to what we want and checklist assessments or insurance information, and then maybe getting back to the reason they said they were feeling miserable. Their decision to be unengaged is understandable, and if we want to engage them, we must treat them differently. The other thing is they feel like they can't be understood because they feel their life experience is radically different than the people they're talking to. The people trying to engage them are successfully employed, have successfully gone through education, we dress different, we talk different, we deport ourselves different, and that is glaringly obvious to them. And they're going to be comfortable talking to somebody that dresses, acts, and deports themselves like they do.
Yeah, I would say individuals suffering from severe mental illness, many times, it's a lifelong illness. And they're not just struggling to engage with providers, they're just struggling to engage in general with, their jobs, their relationships, any other resources that they might be engaged in. And it's a lifelong illness, a lifelong journey. I think what we can do on the provider side, where we struggle, is really having those welcoming front doors for these communities and these patients, right? And that's some of the work that we do in our health system, is just to make sure that when that first call comes in, that is somebody who has some empathy and understands where you're coming from and is able to have some resources that are there to help you immediately. But I think the main point over there is just expecting a lack of engagement and also creating the most welcoming doors we can.
Yeah, Dr. Parks, I really like the observation you had about basically asking people how they want to be treated. I'm curious, like, has anything surprised you as you've gone out and asked that question?
You know, our peers, that is the first question they ask somebody when they agree to talk to us at all, which often takes 6 attempts or so to get there. But about half the time, what they need is a social determinant of health problem. They need a ride someplace. They need diapers for the kids. They need some food. And they're really not going to be interested in their health care until they get these immediate sustenance and what I need to get through the day stuff. If we're going to engage them, we have to be able to respond to that. The second thing they usually ask for is not a comprehensive assessment or a health risk assessment. They have a particular urgent care need. My back hurts. I couldn't get this refilled. I missed 3 visits and I got kicked out of the practice. So if we're going to engage them, half the time it wasn't anything clinical, but to get to clinical, I had to do that. The second thing is the clinical thing they wanted was immediate and concrete. It wasn't sweeping and strategic. And we jump to sweeping and strategic, and they just say, go.
Yeah, and I worked at community health centers, and the first intake appointment many times feels like a wallet biopsy, right? Like, you come in, what is your insurance? How much do you make per year? Okay, so you don't have insurance. We can connect you with resources. Get me your tax return, so it can be a very discouraging experience.
You know, I'm grateful to seriously mentally ill people for being this tough with us. Because a lot of other people that aren't seriously mentally ill feel this way about the healthcare system too. A lot of people. My daughter has a website called Pissed Off Patients, POP. Look up POP. You will hear at length what I get to hear at home.
So a part of serving this population, this group of people, is long gaps in kind of treatment between recovery, non-adherence, relapse. How do you look at the engagement question with that particular component of serving this population?
Well, I think we have to invest in long-term engagements, right? Long-term relationships. And as I said, we have to expect that there will not be that level of engagement, perhaps from the patient, but we should be willing to meet them when they come, right? But when we have those touch points, it's really so important that we invest in creating a good engagement at that touch point. So I think, in behavioral health, we have a big front door problem, right? That's one place when somebody's seeking help, right? Just the complexity of what all the levels of services, what service is the right service for me. So, for example, what we have done in our health system is create a navigation hub where individuals can call directly and speak directly to a licensed mental health counselor. So they are sort of giving them a level of care assessment and also an urgency need, and then being able to refer them to our urgent care center, crisis center, or inpatient, outpatient services as the need may be, right? The next level is, I think, especially with severe mental illness, people who get admitted to the hospitals, we also have that problem when they are transitioning care, sort of the backdoor problem, right? Just having access to the right level of care, creating warm handoffs at that time. We've invested with some of our community-based organizations to create a transitions of care program, right? So as you talked about care management in the community, especially in those difficult transitions, or as they call the critical transition, critical time interventions. I think those are the key areas where we can look at. On the outpatient, we've invested a lot on long-acting injectables, for example, so that we can improve medication compliance, and then also care management support that we can provide. And finally, I think I'll just say one more point about integrating into the community. I think it's so important to get out of our offices and buildings and just go to the community. So for that, for us, that has meant integrating behavioral health in primary care spaces, in school-based clinics, in colleges. And recently, we actually started, we got a grant We're really excited about this program where we're actually embedding counselors in faith-based organizations. So out in New York, we are putting in a counselor at an Islamic center in Long Island, and one in Queens, and one in Harlem. And I'm really looking forward to see how that program goes. But I'm really getting to the trusted members of the community, whether they're doctors, they're priests, or whoever that might be, and engaging those individuals in creating awareness and bringing those patients into our fold.
I guess I'd go in two veins with this. What do you do if you haven't heard from them for a while? And what do you do when you do hear from them after a while, if it's been a while? So if we haven't heard from them for a while, we have periods set at which point we reach out. And we vary that by how ill and how sick they've been recently. If they've been relatively stable for a while, we let it go longer. If they've been struggling, we check in more often. And when we check in, it's the thing, just, hey, how you doing? It's not about anything more than that until we see where they're going with it. It's interesting how many times we call up, hey, how you're doing? They say, oh, I'm in the hospital right now. I'm glad you called me. Well, we wouldn't have known they're in the hospital if we hadn't called to see how they're doing, which is good to know because now we can do a transition of care. I think the other thing is to bear in mind what the nature of the illness is. These illnesses, if you read the cognitive consequences, people have trouble with memory, attention, perseverance on task. So if they call you up and you have an automated call system and you have to remember what button to press with each, that's a hell of a good cognitive test. And then you got to get patient enough to go through the 3 tiers of it. And then you finally get a recording or at the beginning saying, if this is emergency, go away and call somebody else. We train, this is like putting the congestive heart failure clinic up 3 stairs of floor, 3 stairs, and then being surprised why people don't come to clinic, you know? So you have a live person answer the phone right away. What can I do? What's wrong? And then they have trouble with perseverance and patience and memory, so you got to get back to them in about 6 hours. You can't push it out very far. You got to get back to them fast and concrete. And that's what keeps them engaged. If they know you're somebody that'll listen to what they're saying, talk to them immediately and do something about what they raised.
That's great. Anything you want to add?
No, I was just going to say, to your point, Dr. Parks, just around the capacity for providers to be able to continually have that outreach, even when an individual has gone disengaged. That's quite honestly something that, as a healthcare internal case management program, it's a typical like 3 outreach, I'm done, I need to move on to the next person. We really are strongly encouraging providers that have the resources and capabilities to deploy staff with the persistence and the relationship building skills to continue those outreach efforts, that you'll see that the engagement for individuals with SMI will continue.
And what helps us tremendously is the sharing of information that we get. You know, we get to use the previous claims information, so we know a great deal about what kind of illnesses they've had, what their pharmacies are, who their other providers are, which makes it much easier to not have to play 100 questions to figure out who you're working with. You know, we don't have to ask them all that unnecessary stuff, half of which they don't remember or get right anyway, so we don't waste their time gathering bad, inaccurate information. So it's a wonderful partnership and a way to improve the quality and also the friendliness of care.
How have you seen that kind of data sharing and the IT infrastructure piece evolve, maybe over the past few years even?
Oh, you know, this has been a lot of the fun behind the scenes wonky stuff with it. You know, we say that we do 2 different things. We do a personal relationship for people that need a personal relationship, but it's actually a data-targeted personal relationship. We look at the population and figure out who needs help, what of all they need is actually feasibly actionable, because a lot of people need help about things that isn't actionable and you couldn't make a difference on it anyway. And then we train the peers on who do they talk to about what issue, and they get to decide how they talk about it and when they get around to it. They may not get around to it for the first 6 interactions, but it's a data-targeted, life-changing personal interaction. It's a dose-response curve. The active agreement is interaction. How do you decide who, what, and how often? It's really dosing a personal relationship with specific information.
Anything you'd want to add to that?
For us, it has been really the data sharing which we have been able to do with some community-based organizations. So when those transitions are about to happen, we get automated signals that this person is in our emergency department, or they're about to be discharged from the hospital, or being able to send records at time of discharge so that treatment plans are being communicated. I wish we were doing more, but most of this work that I'm talking about is through health information, HIEs. I think they're called health information exchanges, right? That's right. So, that there's a lot of information that's going through that. But talking about the SDOH data, even though the system is doing much better job now with screening people with social determinants, but having something which is real time, which, we tried to create a social vulnerability index a few years ago in our system, but it's really important, as you were saying, to get that data real time, and to be actionable. But I think a lot has been done over the last few years, and even like accessing claims data for the few value-based contracts that we have, we do get claims data, and so we've been able to, for example, run a transitional care management program for certain payers for patients who are being discharged from the hospital. And then just being able to evaluate using the claims data if that's making any dent in the cost of care. Those things are really important, I think, for us.
Can you say a little more about that program? Like, what are you learning through that transition to care program?
Yeah, so we actually were supposed to go live on March 2020, and we had to push that out for 2 years. But it's really a program where certain payers, when patients get admitted on our inpatient sites, we will have a care manager go and visit them at time of, when the discharge planning is about to start, and then make sure that a warm handoff has happened to a community provider or to a internal Northwell provider, and then have follow-up visits. So we started initially thinking about 30 to 60 days, but I think now we do it to roughly 90 days. New York State actually has adopted a CTI model, which is the critical time intervention, which I said earlier, and have recently funded some of our community-based partners to develop these very similar program. So there are about very prescribed 8 to 9 touch points that happen during the first few months of discharge. And then just looking at if that data has been able to help reduce readmissions or affect the total cost of care.
Crystal,
Yeah.
Go ahead, Kristen.
You're sure? So I do think that at Optum, our goal is to be able to share as much information that we have to be able to support all of our providers. We're not trying to hide secrets. We really are ultimately wanting to ensure that there are improved health outcomes, that the member experience, especially for this population, is an improved and enhanced experience. As Dr. Parks mentioned, we do offer an array of reporting that definitely enhances that experience for providers. For some of our programs who have more of a specialty flavor of value-based programming, we do have claims data that integrates holistically medical claims, behavioral health claims, pharmacy claims, really telling the provider not only where the individual is going for care, who are they seeing, when was the last time they had the appointment, even to the level of what medication they're prescribed and what pharmacy they're going to or not going to get that medication. It really is a full clinical journey of that individual that helps clinical decision support from the provider, and also really allows a provider to population stratify. So to your point, making sure that we're targeting the right individuals for the right programs and interventions. Outside of that specialty program, I would say that from a provider enablement perspective, we do have what we consider like best-in-class reporting that we do deploy with a lot of our other standard programs. Those also offer the same type of clinical decision-making data, all the way through daily ADTs, medication adherence reports, risk data, and we can also provide information on gaps of care. So it is like no secrets that we're trying to leave. We want to make sure that ultimately we're having shared outcomes, that not only are you able to engage your population where they need it the most, but are we making sure that the members are getting better?
And this makes such a difference. We take that claims information and we put it on a clinical snapshot dashboard. It's about 2 pages. It takes about 3 to 4 minutes to read through. But it's 3 years of all their procedures, all their diagnoses, all their ER visits, all their hospitals, their meds, with little indicators for how long they were taken in the adherence. So I still see patients in regular practice outside of firsthand. And when I see patients there, they come in, I don't know nothing, they tell me their story, it takes forever. When I see a firsthand patient, before I open this dashboard, I know what to ask about. Or if they call in and they say, I'm getting manic, Parks, what do I do? I know when they were manic before. I know that they weren't manic, they were psychotic, and that might be coming next. It is so valuable, both in terms of efficiency and quality, to share that. That's one of the best things of our partnership.
Yeah, so another kind of engagement piece, SMI, obviously, a really big umbrella. A lot is underneath that kind of umbrella. How do you look at the service delivery for like the different clinical presentations, different severity? How do you get more nuanced beyond just like SMI?
I can give you an example of what we do in our health system. As I said, it's a pretty large health system. We have over 600 inpatient beds and multiple outpatient programs across the system. We've tried to really create a strategy based on pillars of, starting from digital or like self-care to all the way to subspecialty and then inpatient care, right? So starting from, meeting that person, as I said, through a virtual navigation hub, getting to the right level of care, and then once they are actually, if they have severe mental illnesses, for example, a big thing in our standardized assessment that we have developed, right? There are certain questions if you have been admitted in a hospital before, if you have been diagnosed with certain illness, or if you've had, symptoms of psychosis, for example, tells us, okay, you fall into that category, right? And then making sure that that person is then matched to the right level of service. And how we have to sort of develop the services are we have hospital-based clinics in a large health system like us, which primarily focus on patients suffering from severe mental illness. They have Medicaid or state assistance. And then we have suburban sort of practices, which are more focused on mild to moderate or mood disorder clinics, I would say, where we serve most of our commercially insured population. So there's stratification in that way. And then in our hospital-based clinics, we have then developed centers or subspecialty clinics. So there's a center of excellence or a subspecialty clinic for bipolar disorder, one for OCD, one for severe depression. And within that, I think the model, as we develop this model over the years, what's happened is that, okay, that center gets like those 50, 60, 100 patients, and then they're full, right? And then there's a waiting list to get in. And then they're like, well, this patient's really not for our center. You can manage that over there. And we do just this. One of our centers pretty much runs like an NIH study. They will do an evaluation. I mean, they're great measurement-based care, but you have to just the barrier to get into that. And it's like our own program, and just to get the person right there. So I'm just telling you like the pros and cons of doing those things. So recently, what we have been working on what we call our center strategy or the subspecialty programs is how do we make it a consultative model, right? So yes, you don't have to own the patient, but I do really want this patient to be seen by that OCD expert, right? Or that psychopharmacology expert. What can we do to, decrease polypharmacy for this patient, whatever the situation might be. And then we've also developed some trainings, and we have a clozapine clinic. We're big on making sure that the right patients get the right antipsychotics, and then on LAI, long-acting injectables, which can be costly in the front end, but I think they're really great for medication adherence. So how do we create trainings? How do we create QI, performance improvement projects within our system? Again, using data to see what are our prescribing habits of our physicians, so that we are disseminating the best clinical practices of a subspecialty clinic to all our providers. So those are some ways we have sort of approached this to tackle it, at least at our health system.
So we have we rank some health indicators, or we actually call them self-management indicators. To what extent can the person successfully manage their life? And some of them would be, have they been to the ER or hospital lately? Some might be, Have they had legal problems, home instability, those kind of social problems lately? Someone might be of the uncontrolled drug use. And depending on that, we might be checking with them no less than every week or no less than once a month. And people doing really good, maybe once every 2-3 months. And on the check, we say, well, how you doing? And are you having any trouble? Are you having any trouble getting what you need? Are you having any trouble with your health, either mentally or physically? Are you thinking of suicide? Say yes to any of that, then they get our immediate, within 6 hours, escalation response. What we do then, though, if they've had an escalation, we check back within, depending on the acuity and promptness, either within 2 or 3 days or 4 to 5 days. Hey, did that work out or not? Did you actually go get that new med or not? Did it work for you or not? So we don't assume that our intervention fixed it. And these levels vary over time, depending on how the person does. If they're if they're doing well for a while, then they drop down to from once a week to once a month. And if they get sicker, then it goes up. It needs to be continuously adjusted. One of the big frustrations and inefficiencies in the system is when we give everybody the same thing all the time. And that's actually reinforced by the business model of fee-for-service, where you have to earn your after you earn your units of care, which incentivizes you to take people that show up regularly and incentivizes you to do the same amount all the time. And this is so much better. It's so much nicer being on a value-based payment where you have the latitude to make these kind of variations.
It's a great example of just kind of a broken system working to get fixed, right? So this is going to be like a pontificating question, an opportunity for you guys to maybe move out of the specific engagement piece. But when you look at this from a system level, like this SMI challenge, a two-parter. Number one, why do you think there's such a focus over the past few years, or an increased focus around SMI, the SMI population? And then what do you see as kind of a big ticket fix in the system that's got to kind of continue to get turned on?
So for me, I think I saw things change attention right after the ACA passed for a while. And I think it came out of the expansion population in Medicaid. Everybody understood they were going to cover this new population, so of course they ran the numbers on them, all these younger people. And they had different patterns when they ran the numbers. And we were interested because they were new and we knew we didn't know. With old populations we assumed we knew, which was a bad assumption, it turned out. Because when you looked at it, they were way heavy on substance use and mental illness. Well, then you start applying the same algorithm you've written for the new population to the old populations. Oh my God, all these real expensive medical people have an overabundance of mental illness and substance use disorders. So it kind of turns out that that's a marker for high medical utilization overall. It's interesting, if you do the statistics, if you ask somebody, do you smoke, there's a 2 out of 3 chance they'll have a substance use disorder or a mental illness. It is the best one-question screening you can do in medicine. They will have one or they have had one if they smoke. Well, do you have a mental illness? Turns out to be the best one-question screening of being a high utilizer in healthcare. And the plans have learned this, and the Medicaid programs have learned this. And I think we want to keep people alive. We learned that they die 25 years younger. That's the right thing to do. And we look at them now because that's where the money is. Dillinger said, why do you rob banks? That's where the money is. Why do you look at the SMI? That's where the money is.
That's such an important point. You come to conferences like this, and you'll see so many sponsors, and a lot of these companies are, I get asked this question a lot, like all these behavioral health disruptors in your space, and I guess I represent the old school stuff, right? Because we work at a health system, and how's that disrupting your care? And I look at our clinics that I just talked about, the inpatient units, and there is no disruption. We're still running the way they were, right? And the folks are really disrupting those Manhattan psychiatrists who are charging cash pay, right? We have whether it's Headway, Alma, Psychiatry, whatever these companies are, and some of you might be here, we're trying to get care for these people who are commercially insured, mild to moderate, or going to large employers, things like that. But you're so right, that's where the money is, right? Yeah. Where is the money in behavioral health? It's actually in severe mental illness, right? Because what is the behavioral health cost? And we have representation from health plans
And the
here.
money,
Yeah.
The money's another problem. The plans want to do more than they've been resourced for. And here's how they got into it. You know, the capitation rates are set on rolling averages year over year. They were based 20 years ago, and they get increased by medical inflation every year across the whole benefit. Well, in the last 15 years, 10 years, demand for mental health is up much more than any other kind of health care. And the unit costs that are up much more than any kind of health care. The med costs, the manpower costs have all outinflated other portions. But the actuaries have never gone back and rebased the rate. They've never rebased the behavioral health component. So since it was chronically underpaid with inadequate access pent up by stigma, reducing stigma releases pent up demand, which increased costs. We've inflated for 15 years at an inadequate rate off an inadequate base. And so, you know, I used to be Medicaid. I would squeeze the plans like crazy. I ran Missouri Medicaid for several years, and I squeezed you hard to do more. And in part, it was fair, and in part, it was unfair because I should have insisted my actuaries rebase, and they hadn't. And boy, we still aren't brave enough to look at that as a nation. That we're trying to do much better with something that is structurally underfunded and in need of just let's go back and run the numbers from the bottom up and see where they land and then talk about the gap and how we get there politically.
Yeah, and I can certainly acknowledge that the payment for individuals engaging that population is not working. We are, you know, as payers and providers, generally reimbursed only after the individual is elected to get into care. People with that are struggling with SMI often don't elect to get into care at first, and if they do, it's usually in an emergency room or inpatient. Couple that with the driving costs of this population, we really need to be innovative and figure out and be nimble of how we're going to find more creative ways to pay for the services and the engagement of this population. Obviously, we're all good at doing different things, right? Yes. But we can't do it alone. So we really need to make sure as a payer, as a provider, that we're working hand in hand to make sure that that's accomplished, and not only being able to save money, not only from the provider's perspective, but also the payer's perspective, because that's important, but also are our members getting better? And we can do that together.
That's great. My iPad's spinning, but we've come to the point in our time where we can open the floor to some questions. I think it's a small enough room that people can...
Or
just
observations or disagreements, egregious errors we've made. We're ready to hear it all.
We got a couple right here.
Hi, thank you all so much. Question, especially regarding engagement. What do you see the role of family caregivers in the context of care for SMI populations, especially when we're already having a growing lack of enough home community-based workers? Do you see self-directed budgets or any similar role being played?
You know, I don't know that I have the experience in self-directed budgets to speak to that, but I do know and can speak to the importance of involving the family. And one nice thing about the peer approach is they don't have all the scruples about talking to family members that us healthcare professionals do. They wade right in and talk to them too. And once you engage the families, you often end up with 2 or 3 more people to take care of. But we've also learned that if we address the needs of the people the identified individual is living with, the identified individual gets better.
Yeah, I mean,
And sometimes if you don't, they'll never get better at all.
when you have severe mental illness in the family, I mean, one person, you have it in the whole family, right? The whole family gets affected. So, yeah, I mean, I think most of our experience on the provider side is just figuring out how to engage the family more. But I think you bring a good point about like how to actually have some kind of support for the caregivers and how do we engage them in the multidisciplinary team.
Yeah, I'll just comment really quick. I'm sorry. Is that I was in a session last week with some really great peers, and the verbiage of generational social drivers came up, and I really hadn't thought about it that way. We know that generationally and genetically that behavioral health conditions can go across families, but thinking about it from the perspective of social drivers, knowing that individuals with SMI oftentimes are crippled by social drivers, and to understand that they're oftentimes growing up with this need, I think is really something that we need to think about more forwardly while we're engaging this population.
Let's go here, and then we'll go here. There was one in the back.
Hi, I'm Megan Hancock, Chief Product Officer at Imagine Pediatrics. So we do integrated medical and behavioral health care. And one of the things that you guys brought up is HIEs and ABT feeds. And so what we're finding across our population is we get a ton of information on our med model patients, our medical model patients, coming through the networks, which is huge for engagement, because being able to reach those families at a moment of need is wildly important. And we see much less data flowing through from a behavioral health perspective. So therefore, we rely on really lagging claims data. So I guess my question is, so like, what is your advice to the community around increasing data access? Because our behavioral health specific EMRs are not certified to participate in networks, and a lot of information still exists under glass. And so we as an organization are also trying to figure out how can we participate as a community to pushing forward. We're responding to TEFCA and all the things, but would love advice.
Oh, you got the expertise.
So, yeah, so this is one area where the behavioral health part of healthcare sector is culturally inappropriate with the rest of the system. We act in a way that is rude. If I refer to anybody else, the orthopedic surgeons, the endocrinologists, I get a letter back thanking me for the referral and telling me the whole thing without sending a release. And in behavioral health, they refer to us, and we refuse to talk to them after that. And then we don't understand why they don't like us very much. You know, it's systematically rude. It is also currently against federal regulation. How many of you know about the ONC CMS interoperability rules on information blocking? Yes. And they actually are enforceable this coming April. We're in the 2-year window prior to. I spend a lot of time talking to our partners in the communities, asking, how you doing with retraining everybody on that information blocking? And are you aware that, you know, if you can share information, you have to share information unless you've recorded the person that says, don't share my information. Take this home, all of you. The old HIPAA, you may share information. You always could share information with another provider. With ONC, if you may share, you must share, unless you've recorded on the chart that the patient said don't share. So as of April, if another provider asks you for a record and you don't have recorded that that patient said don't share my info, you're in violation of federal regulation if you don't promptly share that information. And we need to talk about that at our meetings and among each other and get up to speed. I've seen more people harmed by not sharing than by sharing.
But what about the health plans, right? For them to be sharing behavioral health data or substance use data, sometimes there are like blockages there too.
Take it.
We have lots of ink on paper. Yeah, you know, it's taken a lot of work, and we're still learning that the information that we share obviously must be minimum necessary, and that particularly when thinking about the SMI SUD population, what information can we share that doesn't break 42 CFR, and that we are able to have data use agreements and business associates with our providers that we're sharing this. So we don't just send a mom and pop shop data as soon as we have an in-network provider agreement with them. There really is some thoughtfulness behind making sure that we have everything in place from a security perspective before we're able to share that information specifically with that provider.
Yeah, I mean, I just wanted to reflect on the challenges. And just for, in our own health system, we have 7 different behavioral health EMRs across the system, right? And not all of them actually connect with HIE. Some do, some do not, right? And just to get behavioral health records in HIEs were a challenge a few years ago, I remember, because the system would send everything, but not behavioral health. And the substance use is the hardest one, right? And I just talked to you about the transitional care management program that we're trying to analyze the results of, but I don't have the substance use data from the health plans. They won't send it to me. So I know like some of these people might have gone to a detox or rehab center, right? So how do we really accurately work on this? So I guess, it could be a group therapy session. But.
I have more. It's a great, but let's go to the gentleman here. He's been very patient.
Hey, so Dr. Parks, I was been thinking all session about it. Something you said early on, right, around like meeting people with the problem they're coming to, this concrete and specific problem they're coming to seek with help with, right, rather than some comprehensive assessment. Yet you also mentioned that this is a population where folks are dying 25 years younger, and that's not because like of that specific concrete thing. That's largely because I think of broader unmet health needs they have. So, and as a provider, we're not doing those comprehensive assessments because we think they're fun or a good way to make money. Yeah. Like, so what's a common sense sort of compromise in terms of making sure that this vulnerable population really gets what they need to change that longevity equation while still being solution focused?
I think, let me use the fishing narrative. You got to get the fish on the hook and keep it on the hook before you get it on the boat. So I think we really have to start with what they need, and we need to keep on pulling towards the things that'll save their life that are about to kill them. But we can't pull so hard that we break the line, and we can't stop pulling or they slip off the hook and they get away. In my own practice, I usually don't think I'm going to get my comprehensive assessment done for the first 5 meetings. And I talk about only what they want the second, a little what I want on the first, little what I want on the second. We conversationally fill in the gaps on the fourth because we know each other but it takes patience and organization. It's not easy. These are tough things. You raise a good issue. And thank you for pointing out they die.
Yeah.
Thank you. Hi, I'm Crystal Thompson. I'm with the Arizona Mad Moms. So we kind of are in that group of parents that work with the most severely mentally ill, typically psychosis disorders. And our group struggles with our kids being placed with us, dangerous situations, not getting help from the clinics, not getting the resources, as well as providers even thinking that we may have a mental illness because we're trying so hard to get our children help. And so I just kind of wanted to, when you mentioned that sometimes the families might have a mental illness, and sometimes the families might be really trying to get their loved ones help, and the system isn't responding to the crisis.
Yes.
I had to bury my ex-husband because my son killed him, and then just this year actually, I had to bury my son.
Oh, I'm sorry.
Both from severe mental illness. And I'm a psychiatric nurse, and I retired from our state hospital after 30 years. So I knew what was wrong with him, and nobody would listen. And so when it comes to families and stuff, and when it comes to HIPAA, we're the ones caring for our kids. And when they're psychotic and sharing information that could be life-saving is really important. And I just wanted to bring that up. Thank you.
I'm sorry. They deserve better care, and you deserve better support.
Absolutely, yeah. Sorry to hear about you've gone through it, but I'm glad that you're working on helping the communities and continuing the advocacy on that. And and the comment about the mental illness of family is not that the family members have mental illness, but because if one person is ill, it just creates that stress or that ongoing trauma, grief, whatever it might be, that you're going through for a long time, and for everybody in the family.
Absolutely. Thank you for sharing that. And panel, thank you all for being here, sharing, and crew here, thanks so much. We'll call it, and thanks for being here.